Hello and welcome to the next episode of the Complete Physio podcast. We're joined today again by Mr. Simon Moyes, a friend of the show, who's going to be talking to us today all about shoulder pain. Now, we have looked at this statistic and we've confirmed it, that 7 to 8 million visits this year to the GP will be because of shoulder pain. So this is a massive problem, and lots of people suffer with shoulder pain for a very, very long period of time. So we're going to talk about all things shoulder today. So Simon, first of all, do you want to just give us an idea of what sort of problems you get in your clinic related to the shoulder?
Well, shoulder pain, yes, is certainly one of the commonest presentations to us in clinic. And there's a background. I remember when I was being trained, if you sort of imagine an X-ray of a chest and you think of everything on that X-ray, from the neck to the lungs, to the heart, to the diaphragm, to the structures beneath the diaphragm like the liver and spleen, all of those structures can theoretically refer you pain to the shoulder. So necks can refer pain to the shoulder, the heart can give you shoulder pain, lungs and pleura can give you shoulder pain. The diaphragm can give you referred shoulder pain. So something in your liver can give you pain up in your right shoulder, your spleen on the left.
That's a good way of thinking about it, because most people can picture a sort of chest X-ray, can't they?
Yeah.
So anything on there could potentially give you shoulder.
So just when someone walks in and says, my shoulder hurts, you just need to have a little bit of a broad spectrum think about what can be the cause of this pain, particularly if it's atypical. And then in the shoulder itself, obviously, the shoulder girdle is very complicated. You know, it's 5 separate joints. You've got your sternoclavicular joint, you've got your acromioclavicular joint, you've got your subacromial joint, you've got your glenohumeral joint, and then you've got your dacrylothoracic joint. And any of those can cause you shoulder pain. And it gets more complicated than that, though, because sometimes more than one of those joints is the problem.
Yeah.
So you and I will often see patients, particularly those of a certain age that are 40 plus, who will have a combination of arthritis of their AC joint. They'll have this condition called subacromial impingement syndrome or rotator cuff syndrome, and they've probably got a whiff of arthritis in the glenohumeral joint as well. So they can have all that thrown in.
So it is a very complicated joint, isn't it?
Yes.
Very complicated. Now, you said something just now about atypical presentation.
Yeah.
So probably people at home now are thinking, well, do I have an atypical presentation? They might have been diagnosed with some sort of shoulder problem, but you've said there's lots of other things that can have this referred pain, as we talk about, to the shoulder. What would be those sort of atypical presentations that you would look out for in patients?
So for the atypical ones, it's probably better to focus more on the typical ones first, I think, and then maybe we'll talk about the atypical presentations first. So, I mean, the commonest cause of shoulder pain that's intrinsic to the shoulder pain is, as we alluded to earlier, this rotator cuff syndrome or subacromial impingement syndrome. And that accounts for 60 or 70% of the people who walk in my door and say, my shoulder hurts. In which case, they have got pain which typically refers to what's called the lateral deltoid or lateral deltoid insertion. The pain will be down here.
Yeah.
The pain can bother them, particularly at night when they're lying on it. They'll get pain when they're using the arm at or around shoulder height. So putting on a jacket or a coat, or going to lift a kettle or a briefcase or something like that, or reaching over to the back of the car to pick something off the back seat.
Getting their luggage down from the...
Yes.
If they're in an aeroplane, that's quite a classic one, or a train.
That's it. And they'll say, they don't localize it very well, but if you get them to point, they'll point roughly to here.
And people often struggle, don't they, to understand that their pain, although it's coming from further up, they often refer it down the arm. Yeah.
It's referred down, and it can even refer further down the arm.
Yeah.
And then there's various tests that you and I would do, and there's about 105 tests or something for the shoulder. But typically they get pain on resisted external rotation, pain on resisted abduction. They'll get pain when you do this sort of rotation test, and they'll have weakness.
Yeah.
So also when you take their top off and you examine them, you'll often see wasting what's called supraspinatus. So you'll get a bit of shallowness here in this fossa up here. But then they may also have some arthritis with the AC joint, which is where the collarbone meets the shoulder blade here on this model. And in that situation, they'll point. It hurts here. Yeah. It hurts here, doctor.
Yeah.
And when you press them, they go, ouch. And that localizes it very well. And then they'll have a different set of signs when you examine them. So, for example, they'll have high pain. They'll have pain when your arm is up here.
Yeah.
And there's something called an O'Brien's test, where you have a sort of Roman emperor test with the thumb down, and you push up, and that will reproduce their pain. You don't know to get pain when you have the pain across the chest like this, or pain behind you. But then you can often get a bit of both. You'll have ACJ pain and some rotator cuff pain.
Yeah. So we're talking about, so those are that's the typical presentation. Yeah. So the atypical is when it actually doesn't present like that. So patients that don't seem to, so we always ask about, as you will, about what are your aggravating factors.
Yes.
And generally localized shoulder problems will have an aggravating factor related to shoulder movement. Yeah. But if it's not typical shoulder movements that aggravate.
Yeah, so if someone's got shoulder pain and you examine their shoulder and none of the standard tests you do on the shoulder are generating the pain, then you're starting to think, the pain is coming from elsewhere.
Or if they've got a medical history that might point towards that.
Correct. So, for example, a very common cause of shoulder pain, as you also well know, is pain that's referred from the neck. So arthritis of the neck is very common. Just about anyone over 40 starts to get degenerative disc disease in their neck, and that will cause pain here in what's called the upper trapezius area. And so they think it's their shoulder, but it's coming from their neck. So you examine their shoulder's normal, but when you examine their neck, you suddenly find that, that's reproducing the pain. And so then you know that it's almost certainly the neck that is generating their shoulder pain.
Yeah, so the neck will often give maybe some pins and needles, numbness, referral, and pain maybe going further down the arm.
Yes.
Not always, though.
So in the neck, you get wear and tear changes in the bottom two levels of the cervical spine. And as you say, that'll cause some symptoms down the arm into the various sort of dermatomes innervated by the lower cervical roots, pain and numbness in the thumb area or the middle finger area. And also weakness. So so you can sort of cast your sort of diagnostic net a little bit.
And then some people will have neck problems and shoulder problems, so they have that mixed bag.
They do, and that is also common as well. So when we investigate them, we have to do a double MRI of the cervical spine and shoulder.
So we've talked about sort of this rotator cuff impingement. So that is one group, and you've talked about AC joint.
Yeah.
The other common one that we'll hear about is frozen shoulder or adhesive capsulitis. Do you want to give us an idea of that, how that classically presents?
So frozen shoulder is an interesting one because no one fully understands its etiology. So, but there's a number of factors that will predispose you to it. So if you've got genes that hail from the Far East, you're more likely to get it. Again, if you're, female, you're more likely to get it than males. Over a certain age, sort of, I think the Chinese or the Japanese called it 50-something shoulder. And so that will predispose you to it.
Yeah, 40 to 60 years old.
50-plus shoulder, they call it, don't they? Yeah. And then if you've got diabetes, if you've had a minor injury, being immobile, sometimes it can be associated with a viral illness.
Yeah.
But that presents with a very nasty pain.
Sometimes you can have it post-trauma as well, can't you? So somebody that's fallen off their bike, got a bit of shoulder pain, 2 months later they've got agony.
And the pain can be very severe. And they don't localize it very well. They just tend to graft the whole shoulder. Some of the patients have been the most severely affected, I think, of all the patients I've seen.
I think it's an very, very painful condition.
And what you have there, which is sort of diagnostic, is a generalized pain, but it's the only real condition where you have a globally restricted range of movement.
Yeah.
So with rotator cuff syndrome, you've got good rotation, but with adhesive capsulitis or frozen shoulder, you've literally got just a jog of external rotation.
It's stuck, isn't it?
Yeah, and you can't get your hand very far behind your back. And again, when you try and elevate it, you can only take it up, 40, 50, 60 degrees or so. And then you diagnose that clinically. Again, we're lucky because we have access to MRI scans, so we can do an MRI scan to confirm the diagnosis, but more importantly, exclude other potential causes for it.
Yeah.
So that's frozen shoulder, and I'm pleased to say that most people with frozen shoulder respond very well to these hydrodilation injections that we do and you do, and are very successful.
Yeah, I think, what would you say, 90% plus now will respond?
80, maybe the right quote.
Yeah, and then they get better, but we also know that frozen shoulder does get better with time as well, doesn't it?
True. If they want to wait it out, they can wait it.
They can,
They can
although
wait 2 or 3 years.
I don't think either of us would do it.
No.
We would get an injection done, and then there's probably still a small percentage that you might do an operation on, or is that?
So
Certainly you used to do
80% will respond to injections, which means 10 to 20 aren't.
Yeah.
And then if you're in the unlucky group, you say you can either wait it out, or we can do what's called an arthroscopic arthrolysis, which is where we put cameras in the shoulder and release all the inflamed
tissue
and scarred tissue in the shoulder. And that works well.
Yeah.
But it's an operation.
Yeah, absolutely. So let's go back to the one that we see most of, with that sort of 60% probably of the problems we see, which is this rotator cuff syndrome. I mean, it's got lots of different names: rotator cuff syndrome, impingement, subacromial pain syndrome.
Yeah.
So that, the way I look at it is, it's somebody that doesn't have much of an AC joint problem, but it could be mixed, and then somebody that doesn't have a frozen shoulder or a neck problem.
Yeah.
So then you've got this. It's a big group, though, isn't it?
Yeah.
That we see.
Yes.
How would you go about? You talked about doing an MRI scan. What would you be looking for specifically with these sorts?
So we're looking there to confirm the diagnosis, because in private healthcare, we're lucky enough to have access to all the state-of-the-art imaging that we have, and it's just available immediately. So it confirms the diagnosis. It tells us how severe the condition is. Is the tendon inflamed? How badly inflamed is it? Does the tendon have any tearing in it? Because that will influence whether we manage it operatively or non-operatively.
Yeah.
I have to say that 80-90% of these patients are managed non-operatively. We also like to look at the bony architecture of the shoulder in these patients, because here in this model, we can see the AC joint here, we can see the acromion here. And this acromion can either be flat, it can be curved, or it can have a hook on it.
Yeah.
And if it's curved or it's got a hook on it, or if there's bone spikes digging down from this AC joint, or if this ligament is particularly thickened, or if the acromion is downwardly tilted, all of those things conspire to make the space for the underlying tendons less.
Yeah. So when you bring this out to the side,
the tendon will rub.
Yeah.
So once we've confirmed the diagnosis from a history, from examination, and then imaging, be it an MRI or an ultrasound, then we'll normally initiate management. And management is over to you guys with physiotherapy. We sometimes add in injections of steroids into the subacromial space, because what happens with the tendon is once it's rubbing in this space, the tendon swells. The more it swells, the more it rubs, then it gets itself into a vicious cycle. And a good way to break that is to do an ultrasound-guided steroid injection, which we can do in clinic, or you guys can do in your clinic. And then it's normally physiotherapy, which is to open up the subacromial space and work on all the sort of calf strengthening exercises. And the good news is that within 6 or 12 weeks, 80% or more of patients are better.
Yeah, absolutely. And you talked about, let's talk specifically, because there'll be lots of people out there that have been diagnosed with a rotator cuff tear.
Yes.
And you talked about a majority of people, because a majority of these tears, unless there's a sudden incident, if we're talking, we could probably split them into, like we did with our meniscal injuries, we could probably split them into an acute rotator cuff tear and a chronic, or what does get termed, terrible word, degenerative rotator cuff tear. Do you want to talk to us specifically about that and how that would affect your management?
So management of rotator cuff tears can be a bit controversial.
Yes.
And it's often down to what the patient wants, what age group they're in. often more their physiological age rather than their chronological age, and what sports and activities they want to get back to. That's one thing to think about. Then, as you mentioned, there can be the acute tears, which happen when you're snowboarding, you fall over or you fall off your bike. There's an awful event and there's a tearing sensation and you've got a fresh tear. Or it can be an age-related or degenerate tear.
What are you pointing at yourself there, Simon?
Because I'm of an age where I could easily have one and not even know it.
Yeah.
But so I think when you've got the more degenerate tears, these just basically fit with the subacromial impingement type.
So those are the ones where there's not been a specific instant.
Yeah.
And
It's just gradually come on.
Yeah.
You think they've got subacromial impingement syndrome. You assess them. You do your imaging. They do have subacromial impingement syndrome, but they've also got some minor wear changes or age-related changes in the cuff and probably an age-related tear. So you would then manage them in the same way you would manage standard impingement syndrome with injections and physiotherapy.
So what we're saying there is that some rotator cuff tears, and I think this is a really important message because people often get imaging and go, oh no, I've got a rotator cuff tear. But actually some tears, it's not that we don't care about them because it will all be part of the problem, but they're not the ones where you're going to end up seeing a surgeon necessarily for it. And also, I think quite a few studies now show that, and you said it, you termed it age-related change, which I think is a really good term to use. But lots of studies show that if you MRI everybody over the age of 60, I think in some studies up to 50% have a rotator cuff tear, but have no pain.
Correct.
Yeah.
Correct. The only proviso I really have about sort of age-related or degenerative cuff tears is I think in an ideal world, you keep an eye on these. And if they're only mildly symptomatic, that's fine. But if you see them enlarging, particularly if they're enlarging quite fast, then you need to have a conversation with the patient and say, your tear's getting bigger. Do you want it repaired?
But that would only be if their pain is also getting worse.
Yes. And then there's the other group of patients who are the acute cuff tears in the younger and more active group. And then I think they are better off having an early repair.
Yeah. I had a lady, she was 45, but as you said, but she was fit as a fiddle. She did lots of activity. She had a snowboarding injury.
Right.
I saw her a week after, did an ultrasound scan, full thickness tear. She had surgery about 2 days later and she's doing brilliantly.
Yes.
And I've got a question for you, Simon. When you go in an operation and somebody's got a tear, say a rotator cuff tear that's 2 weeks old, or somebody that's got got more of a degenerative tear, what do you see in there? And how does that, why does it mean that with an acute tear you can get you may be able to get a better repair?
So what happens is, if you've had a tear for a long time, the muscles that are attached to those tendons atrophy. Yeah. They undergo fatty change, and we can see that on the MRI scans. You can sometimes see it to a degree on the ultrasound scans. And if the muscle has got fatty change or atrophied or developed fibrous tissue, it means that if you were to repair the tendon, it's technically harder, but also it's more likely to fail, and you're less likely to get a good functional outcome, which is why when you get the fresh tears, it's good to go in early.
So it's more to do with the actual muscle that's obviously attached to the tendon than the actual tendon itself. Because I've always, and I say to my physios, if you've got somebody that is of an operable, if you've got somebody that's very fit and active and they've got a fresh tear, and that's not just the same here, is it? It's everywhere in the body.
True.
And you think they may be a surgical candidate, then get them to see a surgeon as soon as possible to make that informed decision.
Absolutely.
Yeah. And let's go back to people may have heard the term sort of an irreparable tear.
Yes.
So people that have got full thickness tears, which are probably full width, so it's the whole tendon, they're irreparable, which means you can't repair them. What do they look like? What is that subgroup of patients?
Oh, they tend to be older.
Yeah.
They tend, when you ask them questions, to in fact to have had a history of shoulder pain or weakness for some time, normally many years.
Yeah.
Sometimes there's been an event whereby the shoulder's just about been hanging on and they've been able to cope, but they've had a recent event, be it a minor fall or an event that probably tore the last remaining fibers, and then they've now got a point whereby they can't literally elevate their arm at all, and the rotator cuff is no longer stabilizing the ball in the socket anymore, and they have got tears which, as you say, are not repairable.
Yeah, and the muscle would have atrophied massively
over years, and you just can't do anything else other than refer them on for what's called a reverse total shoulder replacement.
Yeah.
The good news is that reverse total shoulder replacements have good outcomes in the right hands.
Yeah, I agree.
Yeah, and in our group here, we've got 3 excellent young shoulder surgeons who do reverse total shoulders very, very well indeed. So yeah, that's a good solution. I think they expect a reverse total shoulder replacement to get you good function up to here.
I've seen them.
And I think you can expect that reverse shoulder replacement to probably last 15 years or so.
I think the issue is what you do to that reverse when it needs revising.
But that is a nightmare.
Right. Okay. That's what I thought. Yeah.
Yes.
Okay. So we've talked about rotator cuff tears a little bit. We've said it's not, just a recap, it's not uncommon to have small tears.
Mm-hmm.
We don't always worry too much about them.
True.
But there will still be, and you see them, I see them, a group of patients that don't have a significant rotator cuff tear. They've had an MRI, they've got a bursitis, maybe they've tried some physio. As you've said, a majority will get better with that. There's definitely a percentage that will need an injection just to give them a little bit of pain relief, particularly if they've got night pain. Mm-hmm. From a surgeon's perspective, so which I have sent many patients to you where you're considering an operation, what are you then specifically looking at?
So in the subgroup, and as you say, it's about 10% of them. So they've had their physio, they've had an injection or two in the subacromial space. They're not getting better, and it's annoying. And you just have to tell them that they've either got to live with it or they have arthroscopic surgery. And the arthroscopic surgery is to correct those anatomic predisposing factors in the shoulder, which is basically turn the bone from being tilted and hooked to one that's nice and flat.
So you would you would shave that?
Yes, I often use the analogy of a door rubbing on a carpet.
Right.
But in this time, it's the tendon which is rubbing on the door. And we basically have to skim the bone to stop that rubbing on the tendon.
Get your plane out.
Yeah, it is that simple. And we remove the bone spurs from the AC joint here. Again, that's a very simple procedure. And if there's a small tear in the cuff, while you're there, you would repair that tendon as well.
Yeah. What about the bursa? There was certainly a phase where surgeons would do a bursectomy. Is that?
I think that's dead and buried now.
I think so, yeah, perfect. Now, I will talk to you about what you said there very flippantly, which is I would repair the rotator cuff.
Yes.
But I'm assuming the post-operative care may vary significantly
so
if you repair it or not.
All right. So if you are a straightforward patient and you've got resistant subacromial impingement syndrome, in other words, you've got rubbing of the tendon underneath the bone spurs we've talked about, all you need is this a shaving operation or subacromial decompression, it's called. That's a quick, easy 20 or 30-minute operation, and you don't need to be in a sling. You can start moving the arm almost the next day, and we let you take it up to 90 degrees for about 6 weeks, and then by 12 weeks, 90% of patients have got a great result. If you have got a cuff tear and we think it's worth repairing, then we have to have an extra conversation as to what that means for your rehab. And if we have to repair the tendon back down onto the bone, that involves putting anchors in the bone, physically stitching the tendon back down to the bone. That's a bigger, more painful operation, and you need to be stuck in a sling for 4 weeks. So that's a drag.
Yes.
That's a drag. And it's not something I would particularly relish myself. And so you have a detailed conversation with the patient as to what that looks like.
So that's going to be more of a total could be a 4 to 6 month recovery, couldn't it? Back to full overhead sports.
Well, I think 3, more like, I quote 3 Yeah, maybe I'm optimistic, as most surgeons are, but I think that's what we talk.
I think to get back to full activity,
Yeah.
because you might start, say, tennis at 3 or 4 months, but actually to get back to the where you were before.
Yeah.
How do you decide when you're in there? Say you've got a small articular partial sided tear of supraspinatus. So for those watching, just a small tear in supraspinatus.
Yeah.
When do you decide that tear has to be repaired when you're in there? Or is it more to do with that conversation you have with the
So
patient?
you have a detailed conversation with the patient and talk to them what route A looks like and what route B looks like. And most patients, after you've had a lengthy conversation with them, looked at the scans with them, explained to them on the model what is going on, most of them will want you to get the shoulder as good as you possibly can get it.
Do one operation.
Which usually involves repair, because what you can do is in theory, we don't tend to do it anymore, but what you can do is just do a decompression and see how they are.
Yeah.
And then monitor the tear, and see if that's repairable.
So patient preference, like a lot of these things, is probably quite key there. But then there'll be certain tears where you say, look, it's my opinion that this really does need to be repaired because it's quite significant.
Yes.
Yeah. One thing from a physio point of view is we see lots of post-operative shoulders.
Yeah.
And I think, even when because from a structural point of view, you're repairing everything, you're putting everything back together. But there is a risk, isn't there, after surgery that you end up with a stiff shoulder, particularly with rotator cuff repairs, because you've been in this position. We know that people sometimes develop even frozen shoulder or capsular restriction after that. So and I know you're a big advocate of physio, but it is just to reiterate how important that is, because you don't want to get stiff. And also a lot of these patients have developed lots of secondary problems rather than just the structural problems. So for example, if they haven't played, tennis for a year or whatever it is they enjoy doing, then they develop a lot of muscle weakness, they develop a lot of muscle imbalances, and they got to restore that even once you've repaired the actual structure to get back to full function.
Yes, so I think having a good working relationship with the physiotherapist that you work with is very important.
Yeah.
To have a good line of communication between the doctor, the patient, and the physiotherapist is very important. So if the physiotherapists are concerned that something isn't progressing as it should do, then I think having open lines of communication is really important.
Because although a majority go to plan, don't they? There's always going to be that small percentage.
Yeah, so stiffness is one point.
Yeah.
So as you mentioned, post-rotator cuff repair, people can get adhesive capsulitis. So then you need to think about doing these hydrodistension injections. Yep. And then the timing of those is crucial. We're not supposed to do those until you've hit about 3 months. So people struggle sometimes.
That's because of the repair.
Yeah, because you don't want to do a hydrodistension injection and disrupt the thing you've repaired. So that can be tricky.
Yeah.
And very occasionally, really rarely, people need secondary keyhole surgery to release any scar tissue.
Yeah.
But that is incredibly rare.
I don't think I've ever seen one of yours need that.
No.
And it's difficult to answer this because you're not going to follow up all of your patients. Unfortunately, we don't have 10-year follow-ups on these rotator cuff repairs, which would be pretty cool. How many of these repairs fail?
Oh.
And how many of them, which is the same question, how many of these patients, I suppose a better question is, do you see again that need to have a re-repair?
I think a re-repair is really very rare.
Yeah.
What's more common is they get the same problem in the other shoulder a few years later, with it being the dominant one tends to go first and non-dominant one appears a few years later.
Yeah.
We sometimes see patients about 10 years after repair, and they come back up and they say, my shoulder's hurting again.
Yeah.
And then sadly, by then, they've often got a degenerate, irreparable cuff tear. So your repair has brought them 10, maybe 15 years of a good functioning shoulder, and then later on, they can be in trouble.
Yeah. So actually, and I think the repair, I think that it's difficult because, correct me if I'm wrong here, but I think I've read some stuff on some more longitudinal studies that they re-MRI them, say 5 years later, they do the pain scores and the objective testing, and there was no correlation between the ones that had repaired really well and the ones that had torn.
Yeah, I mean, there's a lot of talk about re-rupture rates post cuff repairs and how well that correlates with function and pain.
Which I suppose is the same as what we see anyway.
Yeah,
is that there often isn't a correlation, but obviously the ones we see in clinic are the ones that are struggling.
Yeah, so I think you need to have a very careful and informed discussion with your patients about what the surgery involves. Do they need the surgery? What the long-term outcomes are?
Yeah.
And I think that's an important thing.
And I think certainly a lot of the patients that we've managed together, it is a bit of a ladder-stepped approach, isn't it? It's a lot of these patients, unless they've had an acute tear, are not seeing you for surgery. They're going to go down the physio route. They're going to go down the injection route if required.
Yes, I use the sort of working through a menu. Yeah. So you just work your way through the menu. You do the easy stuff first.
Yeah.
You do the painkillers, the physio, the injections. And then only then, if that were to fail and you're in the unlucky 10% or so, do you have to do something bigger.
Yeah. But generally, I suppose as a surgeon, you will always only want to operate on the people that you feel are going to do well.
Yes.
Obviously, that.
Yes. You also, sometimes you want to operate on people to stop them getting worse.
Right, yeah.
That's the other
yeah. In terms of particularly those rotator cuff.
Yeah, so if you can see the cuff tears getting bigger over time.
So you'd have to have at least 2 bits of imaging of that, wouldn't you? Brilliant. Well, I think we've done a good overview on that, Simon. Yeah, so thank you very much.
Thank you.
And thanks for joining us on the podcast.
Always a pleasure. Always a pleasure.